yet another excellent talk. Thank you so much. I would just tell all the audience that Dr. Farooq, Dr. Adil may be responding to your questions in the chat functions. They're all here. Nadeem Tehami is here. So please follow the chat also. Meanwhile, I'll request our President of Pakistan Dental Association in Gujranwala, Dr. Hassan, to take here, introduce Dr. Samir Qazi, where he will take a few minutes to tell something specifically about the dental procedures. Yes, Hassan, over to you. Please unmute yourself. And
okay, Dr. Asad, thank you so very much, sir. Like there are no words what you guys are doing for the community and other professionals. So I would like at the end of the meeting, maybe take 2-3 minutes to thank all of these people who are contributing to the cause. So right now, I would like to introduce Dr. Samir. He is an oral surgeon. He is a second generation dentist carrying the legacy of his father. He and his elder brother, Dr. Saqib, are, in few simple words, one of the best among us. And I would like to ask Dr. Samir that, sir, kindly go ahead and after your talk, then we'll be a question answer session. So we will go for that. Okay, thank you very much.
Bismillah ar-Rahman ar-Rahim. I would first like to thank all the organizers for inviting me here. Indeed, it's an honor to be here and to represent the dental community. I've worked a few words about myself because I've had a lot of experience in infection control. I worked initially in Ireland in the 90s, but for 17 years, I was back in Pakistan. I worked as professor in CMH Lahore Medical College and Institute of Dentistry and Lahore Medical Dental College. But in the year 2004, under the guidance of Professor Riaz Ali Khan, I wrote the WHO manual for infection control in dentistry. And since then, I've trained about 2,000 people, in this. But COVID-19 has, changed our protocols totally. And, the first thing I would like to maybe say is that I would like to thank Professor Adil for his wonderful talk. And, one of the comments he made was that, the risk of procedures and the risk of procedures in dentistry off the scale. So if we do a comparison, probably, everybody else won't be on the scale at all. We do have data on what measures reduce the amount of aerosol that we generate. And I'll be talking about that a little later, but I would like to share a few slides with you first. And so as you can see, the instruments that are responsible for these aerosols, on the left top is the dental handpiece, runs at a very high 100, 200,000 RPM. And, there's a spray of water with it, which, we mix with saliva and we generate this aerosol that, is not really comparable to anything else. And, similarly, one of the culprits is this scaler on the right, which again, works on an ultrasonic principle and generates huge amounts of aerosol. There's a water spray and there's no way really to, prevent contamination with saliva. Antimicrobial mouth rinses are used, and I'll be talking about them a little later. But in even the slow speed handpieces that, for example, are used for polishing after, procedures like scaling, which is cleaning of teeth, generate a huge amount of aerosol. The triple action syringe on the lower left sprays out a syringe of water and air, or you can have a combination of sprays, which again, generates aerosol. And even nowadays, procedures like radiography is not, intraoral radiography is not really recommended because it induces coughing. And then, again, that cough is going to generate aerosol in your clinic. So, extraoral radiography is nowadays being preferred. So the problem is not only the 80% of dentistry involves these aerosol generating procedures. So literally our whole profession is over the way we knew it. And I want to share this video with you. Hopefully you'll be able to see the amount of aerosol generating. And it's like a engine. And you may be able to notice that the patient is holding a suction. I should be. So the patient is actually holding a suction machine in a suction tube. This is a low volume suction, but it's not doing anything to the aerosol at all. And what you're seeing there are those larger droplets, larger than 5 microns that you can actually see. But even as the aerosol is being generated, moisture is being evaporated from it. And, small sort of, droplet nuclei that contain the virus start floating. Those initial droplets are acted upon by gravity, so they fall to the ground or whatever. But once you get that aerosol, those small tiny particles, then they're basically with the air currents, they'll diffuse just like everything else. Brownian motion will happen. So and there's no escape. The aerosol is about a foot away from the head of the dentist. The patient themselves are exposed to it, our assistants who are holding the suction. So it's a totally different ball game as far as dentistry is concerned. And this is why all dental associations in the world have sort of currently banned routine for by recommending only treatment of dental emergencies, and different associations have released different lists of what they consider to be urgent or emergency treatment, and the recommendations are to sort of just do these procedures. And I'm just showing you this slide because this is the list from the American Dental Association, and I've circled the procedures that may involve the generation of aerosols. So about half the procedures that we're expected to do during this emergency or epidemic phase do involve aerosol generation. So I'm not going to discuss these procedures too much in detail, but let's presume that you need to do an aerosol procedure. What are sort of, the presumptions first? What are the precautions based on? And the first thing is that all patients may be infected. There's no way to filter them out because of this long potential incubation period. Plus, the issue also applies to staff members, so we need to be careful because staff members may infect each other. There's more chance of you, sort of being in the clinic, but this is not our topic today because we're talking about aerosol procedures. But our precautions have to change because the presumption beforehand was that patients are infected, but now we need to be more careful about the staff themselves. And then we know that with respect to aerosols, they may persist for up to 3 hours, after a procedure, and this has implications on when you can enter or leave that room and when to clean it and so forth. That we'll be talking about a little bit. I want to, Professor Adil covered this very well, so I don't need to say much. But information or recommendations from the different international dental organizations has been slow to trickle in. But fortunately, in the last 2 weeks, a lot of dental associations have come out with clear guidelines for this interim period. And it is clear that the minimum requirement for a mask, I'm talking only about aerosol procedures here, the minimum requirement is an N95 mask. The European standards require an N99 or a FFP3 mask. So, but N95 still remains the minimum mask, and obviously it has to be properly fitted. And the second most important thing is a sealed eyewear, something like a goggle that totally protects, because we know that the 3 routes of entry of the virus are nose, mouth, and eyes. So if these 3 areas are protected, then even if everything else gets contaminated, you can wash it. You can be carefully remove every contaminated item and get clean. But these nose, mouth, eye, so we need to sort of test them and make sure that we're wearing them properly. Now, if the coverall that you're wearing is not made of water repellent material or water resistant material, then the current recommendation is to wear a plastic apron underneath it. And in case you don't have these coveralls, then gowns are okay if you're doing aerosol procedures. But the recommendation is to wear the full sleeve plastic apron on top of these gowns. And I've crossed out the mask here. I love this mask, but it has no sort of use alone in aerosol procedure. But you can use it to protect your N95 mask. You can use it on top of it. And that's a really good idea because you may be reusing these N95 masks, and CDC has come up with a document on recommendations on how to reuse them. And in case there are any questions, we can discuss that later on. And remember, when you're wearing a gown, your legs are exposed. So you have to presume that your trousers are infected, and at the end you just change them, send them for laundering, whatever. Same goes for your shoes. Now, in case your head cap is again not water resistant, then after an aerosol procedure, it's in your hair. We know this. Dentists who've been working, who've been doing these procedures, we know that even if we wear protective eyewear, which has side protection, even the inside is contaminated with, when you clean those glasses, it's contaminated with aerosol remnants. So we know that this aerosol gets into every little thing, every piece of clothing. And the face shields can be useful to again protect your other PPE. They do not prevent aerosols, we know that. The droplets, yes, it will help with the droplets. If any part of your face or skin is exposed, you can additionally use these. And none of these should give you a false sense of security that they're protecting you. The aerosol will definitely get in. But I'm going to discuss some other more measures as well. But a lot of people feel that at this time, just wearing this PPE properly is critical. Even if you just do the two things on the left, which are your eyewear and the mask properly, then everything else, you can sort of clean afterwards. So about reduction of aerosols, what are the measures that we can take? And I think one of the things that's going to become a standard before we even examine an oral cavity, now is to do an antimicrobial mouth rinse. And in recent years, we've moved away from, using povidone iodine or hydrogen peroxide, and chlorhexidine has been in fashion. But, evidence from use on other viruses suggests that our recommended mouthwashes, are these two currently. So mouth rinse before even an examination is recommended, especially before an aerosol procedure. And then the use of this rubber dam, will isolate the tooth. In certain procedures, it's possible to do this, and this isolates it from most of the saliva. And, this measure can reduce, aerosols by about 90% if used properly. But all procedures are not possible. And look at the difficulties that this may cause for the patient who has to breathe. And this is one of my main concerns with COVID-19, that, patients who've gone through your screening net, because remember, the patient hasn't come here without being screened. You've checked everything, his temperature, his history, before he's come to this stage. And he's passed all of those tests. So, but we still presume that he's infected. So he's in early stage. And these aerosols are just going to straight away enter his nose because he has to breathe. And they're going to go deep down into his respiratory system. And this may aggravate his infection or cause complications. There's a concern that the virus may even enter the alveoli and, and enter the bloodstream to infect different organs. So you don't want the patient to inhale this aerosol either. And one of the devices that has also shown, significant reduction in the amount of aerosol if used properly is this high volume suction. The low volume saliva ejectors are not really of any use, as we saw in the video, but these other suctions that come with these stiffer endings, can again reduce the aerosol significantly. They have to be held about a centimeter or less than 15 millimeters away from the head of the handpiece that's generating this aerosol, and then it can certainly reduce the risk. And this is what actually it's all about, because when you're doing aerosol procedures, you can't prevent the risk, you can just reduce it. So this is one of the measures that is actually recommended. On this slide are the measures that actually have been recommended currently by different international dental organizations. I'm going to discuss some other measures, which are not evidence-based, but may also help. So fortunately, Professor Adil has talked about these negative pressure or the isolation rooms. But I just want to say that I don't think this is adequate for dentistry. The 10 to 12 airflow changes with the amount of aerosol that we're generating, we need something like 5 or 10 times this much to really be able to get rid of it. So I think maybe for dentistry, we need to rethink this aspect, and I may be talking a little bit more about it. But what about the other reduction procedures that are currently not recommended by any organization? And there may not be enough research on them. But on the left top, are these devices that basically are like a vacuum cleaner that suck in air, and then the air passes through a number of filters before it is released back, and there can be certain different chemicals and stuff in it as well. Or, down here, we have a picture of a locally made one. Innovation is what may save us, you see, because some of these devices are questionable. For example, look at the two methods being used in the middle of the slide. The top one, where the patient is in sort of a cage or a tray or something, and a tent, as it's being called. And you know what you're doing, you're basically concentrating all the aerosol in here, and the patient is inhaling all of this. You know, he has no other option. And but you see, there's potential here, because you could attach it with a suction device, and some people have done this, and it could be useful in some ways. But look at this one down here below, where it's a very simple method where a plastic, the instrument is being taken through a plastic thing. But what is going to happen to the aerosol? It's going straight down his nose, the patient's nose. You know, we're concentrating it. And to prevent this, earplugs have been suggested. And there, when I talked about mouthwashes, one of the recent papers is on about the use of povidone iodine mouth rinses and nasal sprays for not only the patients, but for the doctors themselves, so that in case they're infected, or for prevention of infection. This is, again, hasn't been recommended. It's just one of the recent articles that I read. But we need to really think about all of these innovative measures, which are great, really. And on the right, this is a device that attaches to the suction, and this part retracts the cheeks, and this part as a whole, which sort of takes away the aerosol. So, this is 3D printed. So there's a lot of innovation going on. And, hopefully these things will emerge, the recommended measures. But I want to say here, very importantly, that this is a time of financial crisis, especially for all dentists, because our whole profession is in crisis. And we need to spend our money on sort of research or evidence-based, technology. And, all of these measures probably reduce the risk of infection, but remember that the basic measures will still need to be taken, which are your mask and your corrective eyewear and other EPP, plus other things that we'll be talking about. On the bottom right is the UV light, which may reduce the time, because after a patient has left the surgery, after an aerosol procedure, if you have one of these isolation rooms, or you need to keep it closed for 20 minutes for 5 air changes to take place before you can enter it and clean it. This adds to the time. And then if the room is not properly ventilated, you need to keep it closed for an hour, open a window, keep it closed for an hour, otherwise wait for 3 hours before somebody enters that room even to clean it. So, these measures, which have proven useful for other diseases, may be employed and may reduce our time and may help at the end of the day or in between patients. But as yet, there is no clear-cut recommendation on it. But, our experience from using it in other situations, there's some hope there. So, ladies and gentlemen, I just want to remind that the standard precautions stay the same, but our protocols change the same in the sense that the list is the same, the headings are the same. Now, I'm not going to talk about a lot of these other things because there's so much information out there. But when we need to do this aerosol procedure, I just want to say that it's critical to remove all unnecessary items from the surgery where the procedure is going to take place. Because remember, at the end, we have to clean and disinfect every single surface. The virus is everywhere. So you just make your lives difficult. There's also an issue of even opening up small containers and bottles in the room during a procedure, because it's going to get contaminated. So you need to be either very well organized and have your materials and equipment ready, when you enter that surgery, or there needs to be a protocol or a way in which these items can be passed to you in an aseptic manner during the procedure. So there's so much detail here on how this can be done, but generally speaking, you need to get rid of everything, and then you need to have all the other stuff either prepared in the room or in an intermediary or an ante-room next to it, or you can pass stuff through that area. You need to sort of figure this out, and it's beyond the scope of this presentation today. But these protocols need to be developed. Remember that I can't develop a protocol for you. You got to need to do it yourself, because your situation, your resources, and the facilities that you have, you need to work on this. I can certainly teach generation of protocols, which is one of my interests, for infection control in dentistry. Now, a couple of words about the sterilization of reusable equipment. You know, the use of disposable equipment is recommended during this phase. But if you not need to re-sterilize, the step that, you know, of pre-autoclaving disinfection needs to be done thoroughly. And before you start cleaning your equipment, they, you know, all the instruments need to be rinsed and then disinfected. Before then, they can your normal routine sterilization and infection. But this is another topic again, which is more general and not related to. Similarly, disposal of waste and sharps need to be done in a sequence properly. And I'm going to talk about that in one of the next slides. I've already talked about the patient safety. This is one of my main concerns. You know, we sometimes forget that, you know, because we're so concerned about what's going to happen to us, that some of the measures that we're adopting may not be safe for patients themselves. And Professor Adil talked about the number of staff members being, you know, low and working in shifts. So again, you know, these are measures that we will need to take, move towards group practices or work in shifts or rotations to try and minimize, because all it takes is one patient to shut down your practice again. You will reopen, one patient will come in, get treatment, a week later he'll test positive. Now the whole practice has to shut down. All the entire members need to go into quarantine. We have to do contact tracing. All the patients who visited in the last week have to go into quarantine. Whether it's just a crazy situation to be in. So I don't know what we're going to do. And point of care test, you know, sounds so good, but they're probably not going to be accurate enough to minimize our risk. Again, you can sort of minimize it. And remember, maybe the only solution will be if once everybody has a history of disease and survive, then they may have some sort of immunity or maybe some immunization will come in. But again, this is not my topic for today. But I am very concerned about engineering and, you know, information that we don't have as healthcare professionals, because we need these rooms now. We need to have information about what to filter, how to filter it, what are the airflows going to be like. And I just want to share with you some of our personal experience at the practice that I work in. This is headed by Dr. Qazi, and he installed these 4, exhaust fans. And we calculated that the air flow rate was 50 air changes an hour, you know, which is 5 times the recommended thing. And we thought this sounds pretty good, you know, this must sort of fulfill the thing. But unfortunately, when we tested this, we found that the air, you know, the door had to be kept slightly ajar. And, you know, the space underneath it was not enough for all the airflow. And then the air was being sort of sucked in from the top, and there was not enough, you know, flow in the bottom part of the room. So we tried to sort of test this by putting a sort of tent here, and then the airflow finally, you know, sort of was better. But probably in an ideal situation, what you'd want is that fresh, clean air ducts sort of bring in air from behind the head of the patient, and then, you know, air is taken away near the foot end. This sounds okay, but, you know, we're not engineers. I'm not an engineer. Eddies may be created on the sides, and there may be pockets of air. So we really need help, you know, medical engineers who can help us and guide us, because Professor Adil touched on this, that the requirements of these airborne, you know, infection isolation rooms or the negative pressure rooms. And, you know, in addition to the filters, you know, everything has to be sealed, even the electricity connections have to be sealed. And then the fans and ductwork move air in the right position. And then there's usually an intermediate environment, which is around, you know, 6 air changes an hour. And so that, you know, this opens into this isolation room. So this may actually be a very useful thing in case we're redesigning our clinics, to have this area to pass, you know, instruments and equipment in during a procedure. So I want to end my discussion by just talking about these few things, which is a little more than a summary. You know, the recommendation is to avoid it. So, you know, I talked about what we can do in this emergency situation, but really the recommendation is to try and somehow avoid it. And Professor Adil has talked about telemedicine, teledentistry is very much possible. Similarly, if you actually at the end going to give antibiotics or painkillers, it's best to do this on the phone, you know, rather than to have a physical contact with the patient. Our minimum requirement for an aerosol procedure is an N95 mask. N99s are better. And then eyewear is the other critical bit. I've talked about the other PPE, but don't let that, you know, put you in a sort of give you a sense of false security. Now, the sequence of what you do after a procedure has to be carefully worked out at every practice. But basically, you will remove your PPE first. Most of it may be doffed in the room itself, but the mask certainly and eyewear needs to be kept on before you leave, and then disinfect your hands and then follow these procedures. There's a lot of information and videos available, because the whole thing is that if you don't wear it properly and then you don't take it off properly, there's no point in wearing it. So, you know, and a lot of the good news for dentists, that even though we have these major concerns, but as yet there's no documented case of, you know, this spreading through aerosol procedures in dentistry, even though, you know, this is going to happen very, very frequently, because as yet all of these procedures are banned. The whole world is not doing them. But if we start doing them and we don't take these adequate precautions, so our clinics are going to become these hospitals. They'll just be closed again anyway. Now, once you've removed your PPE, please take a shower. You know, Professor Adil talked about the precautions at home, and they were so close to my heart, because we all at the end of the day need to go home. And he very, very nicely taught about how to, you know, disinfect yourself, but, you know, clean yourself totally. And there's a lot of detail here that I'm not going into. And then finally, the surgery can be disinfected. If you've got the negative pressure room after 20 minutes, if you've got a reasonably well ventilated room after 1 hour, you can enter and clean it. And this is why in dentistry, we need more frequent air changes, so that in 5 or 10 minutes after a procedure, you know, you can at least enter the room and clean it without, you know. So ladies and gentlemen, I want to thank you for your interest and for your attention. And I want to thank all the organizers. And
Thank you, Samir.
Samir. Asan Samir, Amir ki tarah, Samir is my name. मैं सिर्फ एक दफा चाह रहा हूँ और नहीं okay. मैं सिर्फ ये एक दवा करना चाह रहा हूँ कि you know I hope and pray कि हमें you know Allah Miyan through His Rahmaniyat gives us all the knowledge and information and all the facilities and resources to, you know, fight this problem. And through His Rahimiyat, may He, you know, continue to bless us and keep us safe, and, you know, and may we have positive outcomes of all the efforts that we do. Thank you very much.
Thank you, Samir. It's a wonderful talk. और मैं आपको ये बताऊं कि इस close to 250 people are still logged in. So I haven't seen it in my COVID